Well, we're just about ready to reconvene here. Everyone could take their seats. Yes? Dr. Walden, could you find your way back to your seat, please?
Yeah, I can't.
So I was reminded by a member of the audience who said that they can only hear half of what's being said. So when task force members talk, make sure you talk into the microphone. And so where we've left off is now talking about specifically the additional training that perhaps PTs should go through before practicing physical therapy on animals. And if I'm going to defer over to this side of the room to perhaps address that point.
Okay, so I will say that my experience comes almost entirely from the canine side. There are currently 2 recognized equine rehab training programs that physical therapists can attend, and 2 canine rehabilitation programs that they can attend. And the programs are relatively similar. So I think that my description of what I'm very familiar with, which is what we do at the Canine Rehab Institute, would be very close to what is offered at the other programs as well. Just as background, at CRI, we have been doing this since 2002. We have approximately 1,200 people who have gone through the program, 1,000 of whom are currently certified. The others are completing certification. And of those, approximately 175 are physical therapists who have been certified by us. The training consists of 3 modules, 3 periods spent in classroom with us. Each of the modules has an online pre-course requirement associated with it. So the classroom time amounts to 104 hours of contact time in the classroom, split between these 3 modules. And then there's another 24 to 25 hours of online work that is involved as pre-course preparation before taking part in the classroom sessions. To complete the program, physical therapists as well as veterinarians then do a 40-hour internship at a site with someone who is already certified, either a vet or a physical therapist who's already certified. So the curriculum that we have is one that we developed, though it's also in keeping with the regulations in Colorado for the legislative change that happened in Colorado, allowing physical therapists to work with indirect supervision as long as they have completed the following steps. They have to have an active physical therapy license. They then have to complete 120 hours of contact time in some animal rehabilitation training program that is approved by the state of Colorado. They then have to do 80 hours of internship with a veterinarian in the state of Colorado. Once they have these steps completed, they register with the state of Colorado as a registered animal rehabilitation therapist. Then, in order for them to work with an animal, the animal must have veterinary medical clearance, which means that there is a veterinarian of record who has seen the dog or the patient within the prior 6 months. They have a working veterinary diagnosis, and the veterinarian has given clearance, which means the okay that they approve having this animal then receive physical therapy treatment. Once that animal is treated by the PT, they're required to have medical record exchange with the veterinarian of record within 48 hours of any treatment that they provide. And to date, since this legislative change happened in 2007, there have been exactly 0 public complaints regarding physical therapists treating animals. So the curriculum that we developed and that is approved in Colorado for that particular Practice Act involves training in animal behavior, and specifically in our program, of course, we're talking about canine behavior, as well as handling and restraint. There's an extensive period of time spent on anatomy, and I will say that in my experience, I'm the one who teaches the anatomy. The PTs can run circles around the veterinarians when it comes to their understanding of musculoskeletal anatomy, and the veterinarians consistently kind of chuckle about how much they'd forgotten about muscular anatomy in their years. We train physiology, canine physiology, and comparative physiology for the PT's sake. We work extensively on biomechanics. We train on surgical pathology. The PTs are taught on infectious diseases. We do go over musculoskeletal imaging and the options that are available to the canine patient. PTs are taught extensively on red flags, those things that should alert them that this patient is not a candidate for rehabilitation without first seeing the veterinarian. And then the topic of modalities, I think we got into that earlier today, and I think there's perhaps a terminology challenge going on here, in that modalities, when you're talking to someone who's in the physical therapy world, they are talking to you not about all of their techniques. They're talking about specifically the physical modalities that are used. And those are things such as electrical stimulation, therapeutic ultrasound, that sort of thing. And so we do train how to use the modalities on canine patients. But in this situation, the PTs come in with the vast knowledge. This is something that they use every single day, and so they bring that to us, and what we train them on is the anatomy, where the motor points are for applying the electrodes of an E-stim, for instance. But they understand the parameters of the device, how it's used, the different options for using it, contraindications for using it. These are all things that the veterinarians in the program have to learn from scratch. The PTs come in saying, this is something I use every single day. Bandaging and orthotics and prosthetics are taught in our program as well. And finally, the big emphasis is on collaboration and how the team works together, how a veterinarian, an RVT, and a physical therapist can collaborate and work together to the maximal benefit of the patient.
Okay, so again, I'd like to remind the task force members to try to stay on topic. We will be able to talk about other state practice models and so forth, but let's specifically talk about the education and training that is potentially administered in these programs. And let's also not talk about which person is going to be a better student in those programs. Focus on the program.
Who accredits the CRI program?
There is not yet, though we are pushing for a national accreditation for programs that are training these techniques.
In regards to your exam...
Excuse me, we are RACE approved for continuing education for veterinarians and veterinary technicians. And then we are also approved by Florida, which is our base state, and that's the only place we can do that for CEUs for physical therapists.
Yeah, you bring up RACE approval. RACE is pretty clear that RACE has no role in defining scope of practice and would in no way want RACE-approved CE to be an indication of eligibility to engage in veterinary medicine other than to meet the CE requirements. That's from Jess Klein, who is the program specialist for RACE. So RACE is a division of the AAVSB, which is the state board body, which also has an arm that does CE certification. So you have to submit basically the information that's going to be taught, who the speakers are, what their qualifications are, and then they determine the eligibility of that to be a worthwhile program. And so this CRE program has met the standard that it is approved for veterinarians who want to get X number of hours of CE. My question is really, and has been answered, is about the accreditation of the program itself, overseeing the school. Colorado has a commission of higher education that oversees schools to try and look for things like diploma mills and whatnot. And so it's about the school itself. The other part, I mean, when you're evaluating a program like this, is about the certification exam itself. So tell us about the exam that they take to achieve the certificate.
So in our program, they are given an examination for each of the modules that they take part in. They have to successfully complete each of those exams, and then completing the internship also requires essentially an examination process that they go through with a large amount of documentation that they complete, and they are tested on as they turn that in.
It's an open book exam.
Yes, it is an open book exam. We teach from the perspective that life is an open book exam, and that I wouldn't want my physician to treat me based on something he's remembering, but if he really thinks he needs to go look it up, I'd prefer he goes and looks it up.
How do you validate the pass points of that exam?
We have an extensive process we go through. Our exams are all overseen by Dr. Chris Zink, who is a professor with 35 years experience at Johns Hopkins Medical School, and she's the one who's developed our testing processes and validates our examination process.
So we were talking a little bit earlier today about some board certification. Are those open book exams? Are you aware of any board certifications that have open book exams?
No, they're not open book exams, and we are not professing that we're doing board certification training in our program.
Okay, thanks.
And then Dr. Cho.
Dr. Van Dijk, do you know if your accreditation status is any different than that of University of Tennessee, which is run through the Northeast Seminars?
No, there is not an accreditation process for these programs that train rehabilitation in the United States.
So your status as far as being race approved, do you know if they're race approved as well?
Right.
So they have the same status you do?
Yeah, exactly.
Okay.
I mean, we're both, each of the modules must be race approved in order to get their total approval, right?
Do you know what the comparison is between their educational model and yours?
They're very similar. They have a modular approach as well. And so the topics taught and the number of hours spent and the amount of online content is very similar across the board. The two equine programs are probably more divergent, and I am not as familiar with them as I am with the canines, so I wouldn't try to tell you how many hours of any specific topic they cover.
Thank you.
You mentioned about in the curriculum you teach about red flags when you should refer, as well as comparative anatomy and biomechanics. I was just wondering how much of a time is allocated to those specific topics?
So anatomy is approximately 30 hours between palpation, handling as well as didactic training. The red flags component comes up in probably half to 2/3 of the lectures. There is a red flags component. What to look for, what should alert you that this animal needs to be reassessed. And some of those red flags are for the veterinarians as well as for the PTs. They're things that we understand in rehabilitation training that would indicate you're not getting the progress you should expect from this patient.
So about half, you say approximately half of the lectures, they also mention about the red flags, and about 30 hours of times are talking about comparative anatomy and biomechanics. So exactly how long is the course for them to be able to become certified?
So it's 104 hours of contact time and about 25 hours of online content plus a 40-hour internship.
So that would add up to about 200 hours.
Correct.
Okay.
Kristen?
I just want to, for Shala, for the University of Tennessee program, that they're at the end of the student taking all the modules, that there's a hands-on lab practical that the students have to rotate through lab stations with the instructors, as well as the multiple choice exam, and there are case reports that students are required to submit. And they are not open book examination.
I'm sorry, you said you were seeking accreditation by an accrediting body?
We've been in discussions of finding a way to validate the educational systems that are in place and to make sure that all of us are teaching to the best standards. And at this point, we don't have a national oversight board.
Mention a board, though? Or
Well,
no?
we're in discussions with the American College of Veterinary Sports Medicine and Rehabilitation to see if they could help us with that process.
Who accredits the PT programs, and would they be able to potentially accredit your program?
Well, Colorado's, for a PT to be licensed in Colorado to be an animal therapist, they have to, their education beyond their PT license in animal rehab has to be through a program that's approved by Colorado's Department of Registered.
Approved by
The DORA, and I'm losing their acronym.
by our DCA?
Essentially.
Okay.
Yeah. And so we're approved by Colorado. We meet all of their requirements. Same for Nevada, who has a similar Practice Act.
Yeah. I'm sure you agree about the importance of having some sort of oversight with any sort of program. Potentially, there's two options. Accreditation might be a little bit too rigorous because it's not really a huge program, but similar to what Colorado does, a board approval process is another option, whether or not that be the physical therapy board or the veterinary medical board or the DCA. Those are options too, correct?
So Colorado has spelled out exactly how many hours, minimum number of hours of anatomy, behavior and restraint, infectious diseases, et cetera, that have to be within the program.
Yeah. But within how we do things in California, those are potential avenues that we can talk about. Marianne?
Dr. Van Dijk, I would like to ask you, pursuant to Dr. Cho and Dr. Waldman's observations about different responses to pharmacology and to, I guess you'd say, the biological functioning differences in animals from humans. Do you teach any of that in your course, and would you be willing to add that sort of thing to enhance it?
We discuss pain management, and we get into the common drugs that are often prescribed for the canine patient for pain management. Though it is not unlike the human PT model, where the physical therapists need to be cognizant of the common drugs that their patients are likely to come in the door having had as prescribed medications, and, as well as OTCs. It is not the PT's place to suggest altering those meds or by any means, prescribing or, changing that plan, but being cognizant of those drugs and recognizing how those drugs might impact their patients' abilities or impair them. So we teach that to that level in our program because I think it's vital that a PT who sees a dog who's on pain medications recognizes what the differences in how that dog's body is going to respond to their therapies. But it is beyond the scope of what we're training to get into a pharmacology course per se.
Right. It does make sense to me that you would want to have some sort of education in that realm.
CRI has not been recognized.
Recognize anything about dogs? I'm sorry.
Series out of order.
I was.
I was just saying that I really, that really did have an impact on me to hear what these doctors have said about, that there are things that might be different, and are you training to that? And I would want any physical therapist would want to know that, right off the bat, I would hope.
Right. So they, as I said, they're trained to recognize the common drugs that are prescribed, and as they do in the human model, when a patient comes in on a grocery bag full of prescriptions, refer back or discuss with the referring physician how those drugs are going to impact the PT's ability to pursue treatment with that patient, which comes back to that red flags piece as well.
Thanks.
Nunez?
Ms. Heller and Dr. Cho.
I think what would be helpful for some of us, particularly the public members and the public listening, is maybe kind of a brief case study description. So let me provide you with a hypothetical patient. And maybe you could talk a little bit about how the animal rehabilitation practitioner would handle that case, and in particular also the relationship with the veterinarian. And I'll just pick one of my animals because they're based in reality, and I have a lot of animals that end up needing care. So let's say that I have a dog that has had a TPLO, torn cruciate, 8-year-old dog, has had the surgery, is now post-op. I discuss with my veterinarian whether or not physical therapy or animal rehabilitation, to use the term as we're applying it to veterinary medicine, is appropriate. And the vet says, yes. And I'm given a referral to, we'll say Karen, because she's the practitioner in my community. What happens next? How is that case handled? What specific process do you go through?
Well, you're
not accepting that?
I'm not sure if that's going to address what we're talking about, which is the education and training that occurs in these programs.
Because I want to know how that education and training gets put into practice. And I don't know that. If you just tell me what somebody studied, I'd like to know how that then gets applied.
I think that may be ahead of the discussion.
I could say that a substantial part of our training is also very case-based. So that particular case would be taught. And the training involves helping the physical therapist as well as the veterinarian to understand how to communicate, in this case, with the surgeon. And what we train is to always pursue protocols that are approved by the surgeon. So not just saying, hey, it's a post-op TPLO, here's what I do with TPLOs. Rather, here's how I work with Dr. Nunez's TPLOs, because he likes them treated somewhat differently than Dr. Knapp likes his treated, right? So the dog is evaluated. We train the PT to evaluate the patient, create their problem list. From the problem list, create a therapeutic game plan, treatment plan, and then discuss with the client as well as the referring veterinarian their game plan, what they would like to do, and get approval before proceeding with treatment.
Yeah, and what I might suggest, I think that we have a very good idea of exactly the training that a physical therapist goes through. And we also have a very good idea of what a veterinarian goes through when they're to hash out all the particular details of what this additional training program needs to include might be a huge monumental task that is not best done here. But perhaps we should focus on a mechanism that's going to provide oversight to these additional training programs to assure, and whether or not that be an accreditation process or whether that be a board approval process might be more productive. Val, Ariane, and Val.
Dr. Nunez, you're talking about, seemingly to me, that we've decided that we're going to establish additional training programs, and I'm not sure that we've done that. So is that what you're saying, that we've already decided that?
No, that was tabled because we wanted to talk about the additional training first.
Right, but we haven't decided that yet.
We have not. Carrie Ann, and then Sylvia.
I wonder two things. Who and where are the equine programs situated? Are they comparable? And two, if California does go in a direction of recognizing a program such as Dr. Van Dijk's, that means that will be working with people out of state to certify people or to empower people in this state, and that's something that's done.
Yeah, your question is, can people who have a PT license from out of state, can they go through this program? I think that's a question that the PT board probably can clarify. I assume there's reciprocities for the PTs, just as there are with DVMs.
So as far as, I guess I'm a little confused as to which way we're looking, but PTs from any state can take our course. They have to at least been in practice for at least 1 year before they go through our program, but PTs from any state can take our course. Is your question whether California would have an issue with in some way approving a program that California PTs would attend?
Well, that would be out of the state, you know. I mean, I guess the board would approve the Colorado program and possibly could approve other ones that are equivalent.
We could.
I mean, I think all of the programs are essentially at this point considered sort of a national program or international program. Just we have mailing addresses in certain states, but we train all over. So I don't see where the regional piece would be a problem.
Okay. Mm-hmm.
Well, that's actually a PT who has obtained his or her license in Colorado. They cannot practice PT in California without getting a California license. Is that correct?
Correct.
But potentially, are we saying you have your PT license, but you can practice PT on animals as long as you go through this?
In Colorado, they have to be a Colorado licensed PT in order to register with the state as an animal rehabilitation therapist.
Okay.
Yeah.
Then we can potentially make that same requirement here. Okay.
Well, point of clarification on your question.
Hold on. I'm going to put you onto the list, but we're going to Bill Gage and then, oh boy, then John.
I just want to say, if the task force reaches a decision, a recommendation to the board that there should be additional education and training for physical therapists, and then the board makes, their final recommendation that they believe that should be done in terms of additional training and education, it really kind of falls in our lap, the legislature's lap, in terms of what that education is going to look like, what the training is going to be, validation of examinations. I mean, kind of a decision we make at the legislature in terms of looking at other types of programs through other states, as well as what should be approved or not approved, possibly by the Board of Physical Therapy, in terms of, and possibly maybe a registration program, so we do register those people that they have received the education. Or the conclusion that you reach in terms of...
It's a very complicated process.
and to go into how that's supposed to look and everything, that's something we have to look at.
Dr. Klingborg, Dr. Cho, Dr. Waldman, Ems, Dr. Troy, and then Shalom.
So 3 very quick questions. Is there required CE to maintain the certificate through your program?
At this point, there's not a requirement. We are in the process of developing a program for a requirement, and that's probably going to be implemented by third quarter 2017.
Okay. And then 2 and 3, very quick. What's the cost of your program, and how many graduates last year?
We graduate approximately 100 people. That's vets, vet techs, and PTs in the U.S., and approximately 25 to 30 internationally per year. And then the cost is $6,500 from start to finish.
Dr. Cho, Dr. Waldman, Dr. Sims.
My question was, is there a different curriculum and lecture allocation as far as whether if a DVM comes into your program and a PT comes into the program, are they taught the same thing?
Yeah, they are taught shoulder to shoulder. The vet techs do a slightly different program. So the vets and the physical therapists take the same 3 modules and complete an internship. Vet techs take 2 of the same modules, the introductory one and the sports medicine. They take a separate module that's specific to vet techs for the skills that they need.
Okay, so even though the background of education is pretty different between PT and DVM, but the program is essentially the same.
Right, they are taught at the same time.
Okay.
They receive the same online programming. There are clearly lectures in which the veterinarians are going, this is a good review, and the PTs are taking notes. And there are others where the other happens, the PTs relax and the vets are busy taking notes.
So if the lecturer knows that about 80% of the participants are veterinarians, the how things are weighted would be slightly different and would be targeted to DVMs, correct?
No, so in any given class we'd have, our class size is limited to 30, so in any given class we'd have 20 to 25 vets, 5 or 6 PTs, 5 or 6 vet techs, what we teach in March and what we teach in June is the same.
Yeah, sorry, I didn't make the question clear. Is that if I was a lecturer and I know that my audience is going to be 80% DVMs, I probably skip some of the red flags that I assume that they already know. But I don't know if that's the case.
No, we teach it the same way because we recognize, and we see a lot of it is dialogue, and we see that there's a great deal of training that happens in communication within the group and helping vets to recognize the PT skill set as they're asking and answering, and for the vice versa, for the PTs to recognize the issues that the veterinarians face every day in practice.
And my second question is, after they gain certification, I understand there's more courses they could go through if they wish to. So would you say your vision of the whole veterinary rehabilitation profession is to have an even higher, well-structured, like a 2-year program of some sort? Like a master's degree or something?
I think we have to keep a clarification between people who are becoming certified to do rehabilitation and people who are pursuing board certification, because it's a huge difference in skill levels and the kind of practice you're going to offer. So we do offer continuing education programming for all of our graduates, and we do that in the 3 or 4 modules per year of continuing education programming in things like the nutrition of rehabilitation, geriatric rehabilitation, etc. And so that is part of our plan for requiring continuing education in order to maintain certification, is that we'll have specific CEs that are allowed, whether they be at national meetings or things that we offer or things that Northeast Seminars offers.
And sorry, did I say that was my last question? Okay, this is my last question.
Okay.
So are you aware of any program that actually provide a course or structured course that's longer than 200 hours and targeted on veterinary rehabilitation?
Not that I'm familiar with in the U.S., Europe, or Australia.
I don't know if anyone would like to.
Dr. Waldman, Dr. Sims, Dr. Choi.
So I went through the Canine Rehab Institute certification course, which I really enjoyed. It was a while back, so I can't remember all of the things that I learned there, but I did review my notes. Several important topics that were omitted in my education at this certification program that we're talking about was reading X-rays, interpreting X-rays. Dr. Atlas made note that she reads a radiology report. Maybe in Santa Barbara you have that luxury. In Los Angeles, I have maybe 1 in 30 patients have a radiology report, and probably half of the other ones I don't even have an interpretation of radiographs or X-rays, so I need to be able to do that in my practice. Also, things that were omitted in this particular certifying program were how to take a dog or cat's temperature, what's normal, pulse, heart rate, respiration, whether they're panting from pain or panting from a disease, or even how to address it, how to handle a pet that's collapsed, had a seizure, for which I've seen this many, many times in my practice, how to put on a muzzle, how to actually bandage in a lab situation, what materials we use and how to actually apply it, pharmacology, top to bottom, beginning to end. There was one slide in my coursework that mentioned the meds that veterinarians often use, but nothing about side effects, what to look for, how it may affect comfort or side effects, and how that may affect rehab. And generally, I guess what I'm saying is I loved that course, by the way. I loved it. I learned a lot. It helped me review anatomy so well. It helped spring me into my career as a veterinarian. But all the things I mentioned, I already knew because I learned that in veterinary school. None of those things mentioned a physical therapist has ever been taught to do on a pet, neither in their core curriculum that Dr. Sims mentioned, nor in the certifying program that we're talking about today. And that's fair to me. I don't think that the CRI or the Tennessee program should, in 13 lecture days, tell you how to do all aspects of safety in pets, identifying emergency in pets. Certainly, that's an unfair thing to ask from a program. Certainly, that means that a veterinarian has to be right there alongside of you to help with these things that are missing, that come up every single day in my practice. You know, overall, a case I have today at my clinic.
Point of order. I think we're off agenda here. I think this is now commentary, not a question for the person here. Would you please rule on that?
I think I would like to hear some more.
All I'm saying, Dr. Sims, is that
the objection
is that all I'm talking about is what's covered in the program now, and then how it translates to real practice, which is exactly the topic here. I have a 6-year-old German Shepherd that's paralyzed, that had surgery 5 days ago, staying at my clinic.
If I could, I want to interrupt just for a second. So Ms. Heller's comment was how it translates into practice.
Okay.
And we did not proceed on that vein. This sounds eerily similar to that. I think the question
when you
is
start
before.
with the German Shepherd, that's why
Well,
I cut you
sorry,
off.
I don't.
Okay. We won't talk about the German Shepherd. I'll just say that the skills that weren't taught to me, that I already knew because I'm a vet, are applied every single day in a rehab clinic. And I just want to say that here's a secret that's not going to be a secret after now. I want physical therapists in the future to practice animal physical rehab. And by the way, I'd like them to do it with some autonomy. But the training that exists now, 13 days of a lecture, isn't enough. I would love for Dr. Van Dijk to create a master's program that's 2 to 3 years and really get into safety, pharmacology, diseases. It's not enough time that we have right now. So that's my comment.
Again, this definitely talks about specifics of what we want to see in this additional training program. But again, it might not be fruitful to talk about specifics. I think we agree that there should be a program and possibly a way to provide oversight to that. Dr. Sims. And then Dr. Choi.
I need to pass.
Dr. Choi.
I have a few specific questions, Dr. Van Dijk, since I haven't taken your base course. Could you address how much emergency medicine you cover in case of a crisis, how much endocrinology in case you have a diabetic, you have a Addisonian that goes down, what you do about a dog that seizures, dog that comes in with a bulging eye? Do you cover anything outside of musculoskeletal type of orientation with the veterinary patients?
Yes, we do. We are here to discuss the concept of veterinarians working in collaboration with physical therapists. Physical therapists receiving a case would have had it sent to them by the veterinarian, and if the veterinarian sent it with a bulging eye, the PT is going to send it right back with that same bulging eye. The dog comes in and is in a crisis, an endocrinology crisis, the PT is going to send that dog back. So this is not something they're taught that these things exist. They're part of the red flags discussions are about things like Addisonian crises, heart failure, etc. But the PTs are not taught how to practice emergency medicine. They are taught how to recognize a red flag and when a case needs to go back to the veterinarian or should not come in that day.
In my practice, a good number of the patients come to me referred from other veterinarians and have not seen that veterinarian in anywhere from 1 to 6 weeks. You mentioned the Colorado model that gives a 6-month clearance. The vast majority of geriatric patients I work on, their status changes rapidly. I've had cases
and so the
referred to
PTs
me.
recognize it's time for this dog to go back to the veterinarian.
That's what I'm, and thank you. That's what I'm asking you, because if let's say for sake of argument, based on what you're discussing, if a veterinarian writes a medical clearance today and that dog does not present to that physical therapist for, let's say 3 weeks, that might be reasonable. 3 weeks to get medical records together, to get an appointment scheduled that meets everybody's schedule, 3 weeks. And that patient walks in and their status has changed. How does the physical therapist learn to recognize the change in status from what's written on that piece of paper to what they see in front of them?
They learn that through our program, and they learn it just the same way you did, by learning through practice. You learn it in vet school. You're not terribly good at it when you graduate from vet school. You learn it from every day watching dogs walk in the door and saying, you know what, I smell a rat with this one. We're all capable of learning these cues that we see from our patients.
I don't argue that. My concern is that if you do have a dog that comes in, like I had 2 weeks ago, sorry for the mention, with a hemoabdomen, I was able to treat that dog. What would a physical therapist do with
and I think
someone's
that
dog in that
this
case?
line of argument might start to be discussed when we talk about supervision, which we will talk about. But again, trying to stay focused on the actual additional training that we've talked about that PTs should go through before they practice physical therapy on animals. Your points, I think, are maybe potentially a little bit better brought up when we talk about supervision, because they're saying that they address the concerns that you raise, and now you're talking about how do we assure that, and that could be covered under supervision. Shala, Kristen, Dr. Cho.
I'd like to get back at some point to Dr. Heller's question. I think as a consumer and the end decider and the ultimate decider of how my animal is treated and by whom, I think it's a really important question that she asked. What happens after the animal goes to physical therapy, and how does the collaboration work? I think that would be very important to me. So if we can swing back to that at some point, I'd appreciate it.
Mr. Chairman, I think there would be room for that discussion in either 9D supervision or 9E practice settings. So get there. I would suggest as the board go forward, we're not interrogating each other to some extent. It seems kind of unfair to somebody say, what would the PT do in this case? I think Dr. Van Dijk is telling the curriculum that you provide at your at your educational tools. Anything else calls for speculation as to what an individual PT would do in a particularized situation. So I think we can figure out if the task force or the public has questions about what is taught in these educational settings or institutions. I think that's fair game. Calling for speculation about what an individualized PT would do in an individualized set of facts, I'm a little afraid that that's kind of outside the scope of our agenda item.
Dr. Cho.
Since we keep talking about the Colorado practice model, I could not find anywhere of a specific mention of a certification, and we're just talking about hours from somewhere, correct? If you could expand on that, like, is it for race approved, or is it from a certain organization or something like that?
They don't limit who offers it. They do describe the number of hours. That person has to be able to show that they have received continuing education from a veterinary provider on those topics.
Okay, so it's from a veterinary provider, not, okay. Thank you for the clarification.
Dr. Cho.
So you mentioned when we were in the discussion of what happens if something, how do you recognize, and you mentioned that we just all learn the same way by in practice, but I like to point the difference is, sorry, let me rephrase it. My question is, because I want to stay on the topic. My question is, after the 40 hours of internship, how many of the physical therapists you know actually go and practice under someone's mentorship?
After the 40 hours?
After they are certified. Sorry, after they are certified.
I would have to look back at my specifics, but I would say that the majority of them work with veterinarians in their practices, though clearly in Colorado and in Nevada and in New Hampshire and in Nebraska, that's not a requirement. They have the ability to do indirect supervision.
Whereas most veterinarians coming out from the school, they work under mentorship for a couple years.
Right, and so do PTs when they come out of school. In human.
Sorry, in human.
I would like to actually potentially ask any members of the public to chime in at this point. Please come forward. State your name. And let me know if you like La La Land. I think you need to turn it on. Yeah.
How about that? That works?
Perfect.
Okay. Hello, my name is Cynthia Wallace. I am a horse owner and a dog owner, and I have been a consumer of the services under discussion here today over several years. And to the point of the discussion of the Colorado model and the multi-state board discussions that have come up, I feel that the Colorado model is insufficient for California. I think California needs to be a leader in this area, not a follower. 5 weeks of training with 4 days, less than 4 days, based on the hours that I heard earlier, of the study of anatomy for a physical therapist crossing over species is woefully insignificant compared to what my experience has been with my horses and my dogs. So in the model going forward, I want to see more rigor around the content. Further, a collaborative model is not enough either. I want one throat to choke when something goes wrong. I want to go, and I want that to be a veterinarian. I don't want to have to go to the veterinary board in California, as I'm a California resident. I don't want to have to go to a multi-state board to chase down responsibility and liability. So my request is that the educational model force a construct where the PTs work underneath a veterinarian more than 5 weeks of study before they're allowed to practice on an animal. I can envision having a certified, as described for Colorado or New Hampshire, individual PT coming out to look at my horse because it isn't moving correctly. And I show him a horse that develops an odd movement after 20 minutes when he's ridden. And he looks at it, and the horse starts crow hopping after 20 minutes. Is that vet tech going to know whether it's a physical problem or that horse needs a mental adjustment for resistance? 5 weeks isn't going to teach that. Thank you.
So, again, we're talking about the additional training process that's potentially going to be provided to PTs. We're looking for public comment on that specific issue.
Actually makes it easier.
Your mic is not on.
All right. It actually makes it easier, Mr. Chairman, if you narrow it down to one
please.
topic at a time.
Introduce yourself, please.
What did I say?
Introduce yourself, please.
Oh, I'm sorry. Dr. Jeff Smith. I'm a private practitioner in Lake County and CCRP certified as well. I just want to say on the topic of training that we're talking about, I don't think animal certification of PTs in the 200-hour or 5-week range is in any way comparable to veterinary training. That would be equivalent of 5 weeks of the freshman year of veterinary school, and to sort of try to say that learning the red flags would put them on equal footing with veterinarians, I think it's disingenuous. I think this idea, which I've heard talked about, the team approach to physical therapy, where the veterinarian is involved, really the crux is, are these practitioners going to be supervised or not supervised? And if the veterinarian is involved in this team approach and the physical therapist has this additional training, then I think we're on the right track. But to turn them loose, to practice independently with no supervision, and to try to equate that additional training to a veterinary degree does not make sense.
I don't think I've heard the physical therapists say that a certification puts them on equal footing as a veterinarian. I think the physical therapists have been very, very respectful of the veterinarian.
Chair Nunez, if nobody else is speaking, may I make a brief comment?
Yes.
Because it does address this ongoing issue, and I think I've referred to this a few times. I don't think that anyone has proposed, ever to my knowledge, that physical therapists with advanced training in animal rehab operate independently without veterinary supervision. Correct me if I'm wrong. No, I don't think so.
Well, that's what I just said.
Right. But and the reason I want to articulate it again is because we've had public comment quite appropriately addressing that concern, but I don't think that's even a proposal on the table.
Yeah.
Okay.
Sheila.
I just want to add, it seems to me that people are under the impression. Sorry, it seems to me that people are under the impression that physical therapists want to act as veterinarians, and that's not true. If I understand correctly, physical therapists are offering an adjunct modality that is a specialty field in order to help animals. I have never heard a physical therapist say that they don't want to work with a vet. It's an issue of whether they can work under direct or indirect supervision. They're not circumventing the vets. They're not asking to. I think that's out of the question and hasn't ever come up, if I'm correct. So just expound on what Dr. Heller is saying. That's not the issue. So asking them to have the same training or saying something like it doesn't put them on equal footing, I think is moot.
Karen?
Yeah, I concur. We have never, ever said that we want to treat without a veterinarian involved in the case. We have always, our position has always been that we believe that a veterinary medical clearance is absolutely essential because we are not veterinarians. We believe that we can treat safely after the veterinarian has cleared the animal for rehabilitation. So it actually speaks more to the vet if they're going to refer over to us that if it's a a fragile case that shouldn't be in a PT's hands without a veterinarian on premise, then that particular animal should go to a physical therapist that has a veterinarian on site. However, there are more cases than not that are not the fragile patients, and they are appropriate patients to be seen without a veterinarian needing to be on site as long as the physical therapist has had additional training. We have never said that a physical therapist without additional training should be able to practice animal rehabilitation. So I don't understand why this keeps coming up, that people want to say that we want to be veterinarians or that we are trying to downplay the role of veterinarians. We have always worked in a collaborative setting with physicians and other allied healthcare professionals, and quite frankly, it's the veterinarians I'm finding are not used to that kind of model because the veterinarians have had their the scope with the animals exclusively, so they don't have the experience of working in a collaborative setting. And there was a great letter that was submitted by.
Okay, I'm going to have to interrupt here.
Oh, okay.
I apologize. This
Okay.
is not on this is not on the issue of what kind of training we're getting. So,
okay,
but let's stick. If we've exhausted public comment on this issue, then the task force can determine that they've heard enough. They can move on to 7B. They can say their motions for 10.
Okay, what I propose, we've heard about the certification program that is available. We've heard about some of the concerns that the veterinarians have about what needs to happen in that training and that education. And we've also talked about the possibility of some sort of oversight for these certification programs, whether or not that's in the form of accreditation or in the form of board approval. And we've talked about how we can take that accreditation program and make it as a requirement for physical therapists to practice physical therapy on animals. There's many other things we still have to work out, but with that in mind, I would like for us to take a 10-minute break, 10 minutes, and come back and perhaps think about the possibility of forming this into some sort of motion. 10 minutes. All right, we have had the opportunity for members of the task force to talk about physical therapists, their education and training. We've talked about the certification program that physical therapists could potentially go through in order to practice on animals. We've heard about a lot of concerns about what needs to be covered in this certification program. And we have not talked about supervision, and we have not talked about location. But and we've heard from members of the public. I know that there's also a question that Ms. Heller asked that Shala wants to discuss further. We will. So is there the possibility of some sort of congealing motion or concept that can be made at this point?
Chair Nunez?
Yes.
I'm willing to try something.
Let's hear it.
Okay, because I think you want us to try to make some progress on things.
We need to make progress.
I would like to move, and if this is premature because people still feel like we need to talk about supervision and practice settings before we make a motion, then I will withdraw it, because I'm not clear what order you want things to move in, but I'm trying to follow your leadership. That licensed physical therapist with advanced training in animal rehabilitation as authorized by the state of California, keeping it vague because that goes back to the legislature, be allowed to operate under indirect supervision as defined by the state of California. So again, I'm being vague because we're not supposed to go into a certain level of specificity, which is making hard to make this motion, but I'm also trying to make a motion to move us forward.
Lee, would you be open to an amendment of requiring a veterinary medical clearance prior to that, or did that include that?
That was a level of specificity I didn't get into. It was sort of presumed, but because that would start to specify the specific details of what was required as part of indirect supervision.
Okay.
I see.
I think I've come to a realization that we're not ready.
I thought, but I was trying to help you get there.
So, having said that, I wonder if we can maybe start to talk about another topic now, and that is levels of supervision. Let's perhaps throw that one on the table.
Mark? May I ask legal to define what the levels of supervision are that are recognized by the state? Sure.
There are various levels of supervision recognized by the state: direct, indirect. There's also terms in the Business Professions Code, physical presence. There's also medical assistance that can operate with standing orders. So it really runs the gamut. I really do believe that if the task force wants to recommend something to the board, it can certainly do so with whatever terminology it wants: indirect, direct. And I think, as Mr. Gage pointed out, perhaps that could be fleshed out as it moves through the process. I think this task force should focus on conceptually what it wants. So again, there are various levels of supervision. Direct, sometimes direct in some venues and some areas means I'm standing next to you. Some parts of supervision, indirect supervision in some realms of my previous clients means I'm available, or I'm not in this presence, or I review it after the fact. So, whatever methodologies, whatever nomenclature that the task force wants to put on as far as supervision, I believe the world is the task force's oyster. If that's probably a gastronomic disaster, but nonetheless.
So my concern here is if we start to talk about direct and indirect and we've not defined the terms. I mean, I don't know if we're trying to use the terms that we recognize in the Veterinary Practice Act and the Physical Therapy Practice Act, or if when we use a term such as direct or indirect today, we need to also define that to be explicit.
All right.
Since I'm doing so well with topics and scoring position, I'm presuming that the task force perhaps is dispensing with 7B, sort of not perhaps interested at the moment in item number 8, is in a sense focusing its efforts on 9D and 9E. Is that?
Well, we haven't talked about 6.
Okay.
We were talking about 7A and B. I was hoping some sort of motion could come out of it, but it's not going to happen. So I think that we should talk about 9D and 9E, and perhaps after talking about those, something will come together.
Here.
Dr. Sims.
Yeah, I wonder if in the looseness of our adherence to the agenda, we may have almost considered covered 7B and 6. And we would just be able to dispense with those, say that they were embedded in, whether formally or appropriately or not, and go to 8. I think 8 might help us because let's not reinvent the wheel. I think it might help us in terms of 8, agenda item 8, where there may be operational definitions of supervision there. In PT, we have different meanings to supervision of direct and indirect supervision. And so we've got to make sure, and I agree with Dr. Klingborn in terms of operation defining what that might be. But we may already have an answer to our question somewhere in other jurisdictions that might help us, or we just hash out our own brand new one. So I'd move that we kind of dispense with 7B and 6 as already covered.
You know what? I actually tend to agree with that. The discussion on the scope of practice of physical therapist, we are not talking about that. We're talking about creating new languages that it's going to allow physical therapists to practice physical therapy on animals. We're not talking about this. Technically, it's going to expand the scope of practice, but I don't think we need to talk about the scope of practice of physical therapists. And then additional specialties, as Dr. Van Dijk pointed out, we're not talking about board certification. We're talking about a certification program. So perhaps 7B could be stricken. So maybe let's have a motion to strike 6 and 7B.
So moved.
Second.
Any further discussion from members of the task force? Any, Kristen?
I don't know if this is relevant with the additional specialties that the sports medicine specialty, that they don't require any of the current certification programs that we're talking about in order to gain the specialty.
Right. Yeah.
That's all.
Yeah. It's a separate board certification program. Any comments from members of the public? Gotta have one motion passed in this meeting. Call for the vote.
Dr. Noon?
Yes.
Lee Heller?
Aye.
Dr. Klingborg?
Aye.
Karen Atlas?
Aye.
Sandy Gregory?
Aye.
Kristen Hagler?
Aye.
Spring Holland? Dr. Holland? Dr. Schlachter? Dr. Sims?
Aye.
Dr. Troy?
Aye.
Dr. Van Dyke?
Aye.
Dr. Waldman? Dr. Chow? Shala Bar?
Aye.
Bill Gage? Carrie Ann Calais? Valerie Fenstermaker?
Aye.
And Alyssa Silva.
You got your unanimous vote?
I'm excited. So I propose that we talk about supervision in practice settings a bit now. What are your concerns about those issues?
Are we on agenda 8?
What I had said at the very beginning of the meeting is when I changed the order of 6 and 7, I said that I fully do expect that agenda item 9D and E will be included in that discussion. So that's what I'd like to talk about now.
Chair Nunez? So maybe as a way of combining those two, and again, I come at it from the public member's perspective. So I'm not a licensee in any of these professions, which means I don't have this knowledge of the different supervision levels and models. So maybe we could have some description of what, I think we know them in the veterinary field. We talked about that at a previous meeting and voted, but we don't necessarily know about what they look like in these models in other states or physical therapies involved.
Okay,
So-
there's no specific universal definition of
I
those
realize
terms
that. I'm looking for some
because
examples.
because it means different things in different practice acts.
Right, that's why I'm
But
asking for what it,
But I would suggest we're talking about direct supervision means that the supervisor and the person being supervised has to be at the same location. Not necessarily in the same room, but the same location. That's what I'm proposing that this task force understands. Immediate supervision, I think, would imply that they have to be in the same room. Indirect supervision means that the supervisor has allowed the person being supervised to perform a task, but they don't necessarily have to be in the same premise, the same location. Is everyone okay with those
Just
definitions?
a clarification, is this location any location, or is it a veterinary premise?
We haven't gotten that specific yet, but we're just, can we accept location for the time being? Hello?
These are defined already.
They are defined in...
They're defined in 2034 Animal Health Care Task Definitions.
Yes,
under
and if you open up
ENF.
another practice act, you'll see a different definition. If you open up the Dental Practice Act, it might be a different, there's not a universal definition. So it would be helpful for us so that we make the recommendation that we want to have that definition out there. And I proposed a definition for that, and hopefully the task force accepts that.
Have folks on the task force that are confused. It does exist in the Veterinary Practice Act. I think what Kurt was explaining earlier is that we're not confined to that on this task force in terms of if we wanted to think about an alternate type definition that would be utilized for the purposes of animal physical therapy, we would not necessarily be confined to what's in the Practice Act today. You could use that as a good model. It's there. Nevada has definitions. Colorado has definitions. So everyone has definitions. They just, I think the point was made that you have the purview today to figure out what you want that definition to be when we start talking about supervision.
Well,
I know Dr. Klingborg just brought up premises, and I have a hard time having a discussion on supervision without talking about premises, because in the Practice Act it's very clear if you are a supervising veterinarian, that being having a veterinary premises with all of the enormous regulations that go along with having a veterinary premises is very pertinent to this topic, and I don't think we can separate the two that easily, because we've heard referral and now we're talking about supervision. And if you look in Section 2030 of the Veterinary Medicine Practice Act, you can't ignore everything that goes along that pertains directly to animals in a hospital setting.
So going along that path, if we're talking about a premise, I think it's probably it's accepted by every member of this task force that physical therapy can be practiced in a facility that holds a practice permit from the Veterinary Medical Board. Are we in agreement on that? If, physical therapy can be performed in a veterinary animal rehabilitative therapy can be practiced in a veterinary hospital. Right? So we agree, when we're talking about locations, we agree on that point. We are also talking about the possibility of animal physical rehabilitation occurring in a location that does not hold a premise permit from the Veterinary Medical Board, so it's not a veterinary hospital. The point was made, if we are going to talk about allowing that to happen and what level of supervision should occur in those locations, it does make sense for the veterinarian to want to have assurances that that location meets certain standards. Do we agree on that? So potentially we can talk about these off-site locations as holding premise permits. Now, whether or not that's going to be overseen by the Veterinary Medical Board, which already does hospital inspections, or the PT Board, which has the authority to inspect locations but currently does not, also needs to be discussed.
Chernian. I would certainly feel that it was essential to have some kind of premises permit for the practice of animal physical rehabilitation, because whoever the overseeing agency is going to be needs to be able to regulate, license, and inspect as we currently do. I'm just about to go on my first ride along. So, but whether or not that premise permit has to be held by a veterinarian and be identical to a full-service veterinary practice may not be the same thing.
I agree, because along those lines, as a veterinarian, if I diagnose and make a prescription for animal physical rehabilitation, and I am sending it off to a location to have that done, and again, there may be some patients that I don't think I want to send to a distant location, and I would potentially have the authority to say, if it's going to be done, it has to be done here. But if I do send it to another location, I don't necessarily have to go to that site to make sure that it's clean, that it has all the equipment that's necessary to perform the task, because I know that a licensing agency like perhaps the Veterinary Medical Board is going to be doing random inspections and is going to have a set of standards that they must abide by. That's a way to go with this. I think it's reasonable. Carry on.
Yes. Karen, does someone inspect your equipment?
I work out of a veterinarian's office, so I am the premise permit holder is a veterinarian. So yes, we are, we are in the purview of the Veterinary Medical Board to inspect our premises.
Supposing that you were on your own, is there currently, would it be the physical therapy board, or no one would inspect your doggy hydro things, or?
No, that is what we need to figure out now, because right now the PT board is purview is to inspect the premises of human, physical therapists practicing in the human field. So I think that's an important piece to hash out now, is to allow one of the boards to be allowed to inspect our premises if indeed we come to the conclusion that that physical therapists with advanced training can work on on their own premises without a veterinarian on site.
If I could just ask one last question, do you think that that's a good and necessary thing to have things inspected?
Absolutely.
Okay.
It's important for consumer safety, and as Dr. Nunez just pointed out, the veterinarian that would be making the referral, it shouldn't be on them to wonder if that premise is safe or not. They should feel comfortable knowing that there's a body that is overseeing it for them to make the assurance that everything is properly running.
And just for the records, I don't think the physical therapists use a doggy hydro thing. Unless I'm mistaken. Okay. Go.
As far as the premises goes, I think we all agree veterinary medicine should be practiced on veterinary premises for the protection of the animals. And we also agree that animal physical rehabilitation is the practice of veterinary medicine. So we're talking back to protecting the consumer and for the best of the animal. So I really don't think it would be something separate, but if the board goes to that direction, I think a certain distance regulation is needed, because you won't be expecting you to refer your case to somewhere practice 300 miles away, and when something happens, you say go drive 3 hours to see your own doctor. But one step back, I think it should be on the veterinary premises, just because it's a practice of veterinary medicine, and we made the agreement that it's the best for the animals.
All right, Ms. Heller?
And my response would be that we can have more than one kind of veterinary premise license reflecting the kind of veterinary medicine being practiced. So my own inclination, and I'm pretty open about this, is, in terms of if the PT board or the vet med board is going to end up regulating this, obviously different models work in different states. I would be inclined to lead towards the vet med board regulating it, maybe because I'm on the vet med board and I'm pretty impressed with what it does. No, yeah. I don't do the inspections, although I'm trying to go on a ride along. But I think that the idea that there's only one kind of premises license could artificially prevent us from having a more open discussion about what are the basics necessary to ensure consumer protection and quality service provision under the purview of the vet med board. And so it would still be a veterinary premises license, not necessarily held by a veterinarian if the person is a licensed practitioner of a new category, but it has to be somebody that we license and we oversee their premises, just as we do now for veterinarians. But there's some work involved in creating that. Now, Bill has told us that's the legislature's job if we make the conceptual recommendation, so we don't have to figure it out today.
Yeah,
but we
I
can
mean,
conceptualize it today.
I mean, it's an interesting thought because potentially premise permit could be regulated by the veterinary board, but the actual license of the PT is being regulated by the PT board. There's two boards overseeing. And if that's not enough oversight for everyone, I don't know what is. Two boards watching it. Dr. Troy, Val, and Dr. Van Dijk.
I guess I need some clarification. What is the disadvantage of the premises license being held by a veterinarian? Is there a disadvantage of that? If our board issues premises license to veterinarians that practice veterinary medicine on a veterinary premises, why would there not be a veterinarian with that license? Can someone explain that to me?
If in the model of indirect supervision, the PT would be the one responsible for the facility. The veterinarian wouldn't own the facility.
But can the veterinary board then impart any infractions or punishment on the PT?
We can certainly establish rules to that effect. That's what we do in Colorado. The veterinary medical board can inspect the PT's practices.
Which is interesting because in Colorado it's not the practice of veterinary medicine.
But the veterinary board has, the vet med board and the PT board sat down and collaborated, came up with language that made both sides happy. And it's worked beautifully. It only took 2 years.
Val?
So I'm not familiar with the Colorado Practice Act, but I'm pretty familiar with the Veterinary Practice Act. And one of the reasons I think I'd like to bring up the premises more is because, as I said, of Section 2030, where a veterinary licensee manager is responsible for everything in that veterinary practice. And in order to help people who aren't familiar with it, I just want to point out a few parts of it. So in a veterinary premise, you have to have effective separation of known or suspected contagious animals. That's very important for the protection of the animal, for the protection of the public, for the protection of the staff. And if a physical therapist, oh, I'm sorry,
yeah,
it's on. Oh, sorry, I'll speak closer. If a physical therapist is going to send an animal back from a review of their record, it may come in a few weeks later with a contagious disease, and that's something they won't be able to recognize. So how are they going to effectively separate that animal if they can't recognize a contagious disease? Do they have an isolation area as a veterinary premise is required to have? Also, I better get up closer here. Sanitary methods for the disposal of deceased animals shall be provided and maintained. Well, a dog could die at a physical therapy practice if it's a referral. What are they going to do with that dog? There's regulations, state regulations about deceased animals, and veterinarians are quite familiar with what to do with a deceased animal. Are they going to call the owner? Are they going to put it in a car? Are they going to bring it back to the veterinarian? How are they going to dispose of that animal? There are lists and lists of requirements for a premises that veterinary premises are required to have, and I just have a difficult time envisioning a physical therapist being able to follow all of these regulations with their education. I have a great deal of respect for physical therapists, but they're not veterinarians, and I don't think that the regulations of a veterinary practice are going to be that easy, at least in California, which is highly, highly regulated, to be accomplished here.
But if the veterinary medical board sets the standards of these locations, they would be qualified to not only set the standards, but educate the permit holder on how to comply with those standards.
Then I think it should be a veterinarian, because the veterinary medical board has had these in place for many, many years for a reason, and that's because they're based on a veterinarian's knowledge and education and ability to recognize contagious diseases and ability to know what to do, especially if the dog is dying. You can't, if it's a human, what are you going to do? You're going to call 911. If it's an animal, what are you going to do with it if you can't provide that emergency care to save that animal's life? It's a huge difference we're talking about here on a veterinary premises that's equipped to deal with every part of animal care, and we can't even begin to not include the owner in this process, because then you have an owner involved who has a veterinary client-patient relationship with the veterinarian who might be miles and miles away.
Yeah. Does your certification program address the issue of identifying contagious diseases in animals?
Right, that we're required to teach infectious diseases and recognition of those diseases. That is not to say that a covert infection could come in the door anywhere. And I think we have to start looking to it. We're talking about facilities where PTs are going to be offering specific care of musculoskeletal impairments in dogs. They are not holding themselves up to be critical care facilities handling emergency medicine, surgery, etc.
Right.
And I would say that if we're going to go down this path of permits for premises, the same things can happen in a doggy daycare. These dogs can die, have seizures, have infectious diseases, etc., and we're not having this huge task force about regulating doggy daycare centers. I think that we get to a point here where we're kind of being
okay. I think Dr. Sims and then Dr. Waldman and Dr. Choi.
I think you were getting skipped a couple times. Okay. For me, the access for the consumer to choose their practitioner of choice. They'll go through the veterinarian, get the medical clearance, and then I know what practitioner I want to service my animal. And if I'm in a rural area where my veterinarian is in Indio and I live in Blythe, and I have to drive 2 hours every day to get treatment, the dog is potentially, or the cat is going to have. I'm unable to go through that because of the regulatory restriction of not having it such that a physical therapist who lives in Blythe would be able to service that. So I think there is a consideration for access of care and quality care for the animal that this body needs to consider.
Okay. Why?
The argument, Dr. Van Dijk, that you presented is a non sequitur argument. Nobody goes to a doggy daycare expecting to receive veterinary medicine. And we've all agreed that the provision of animal physical rehabilitation is considered to be the provision of veterinary medicine, a part of it. When a dog goes to a doggy daycare, certainly accidents can and do happen. There's no doubt about that. But I don't know of a client that has an expectation that their pet will receive anything more than what is standard for that profession. Our profession, when a dog comes to see me for its bad ear and has a seizure, they expect that I'm going to treat that. If a dog comes in for rehabilitation and collapses, they expect I'm going to treat that, even that's not what its entering complaint is. And that's one of my big concerns, is about patient and client safety. Karen has said that she practices with a veterinarian on her premises. She practices in a veterinary premise. I guess my question for you, Karen, is why is what you're doing now not working? Because it sounds like you're doing what all of us are doing. We're practicing in a veterinary hospital with someone that's educated in providing rehabilitation with a veterinarian on the premise. That if an emergency does occur, that patient and that client has an expectation of safety.
Yeah, and again, I would say that if I am probably going to refer a 3-year-old healthy Labrador to an off-site facility, can it develop a splenic rupture? Yes, it could, but it's not likely. And will I send over a 15-year-old Addisonian Schnauzer? I probably won't. There has to be some compromises made. Well then.
Dr. Nunez, I personally feel like no matter if it's a 3-year-old lab or a 15-year-old geriatric, I want the same quality care for my patients. And I guarantee that pet owner wants the same quality care too. So I don't think, so when we're trying to talk about actually protecting the consumer and protecting the patient, that having a veterinarian involved and supervising directly is even a question for me. The problem that exists with some of the proposed ideas is that the consumer doesn't understand their choices. They don't understand that a physical therapist who may well be exceptionally well educated and qualified with certain training to perform some APR is not a complete look at the health of that patient and managing that patient's care. And that same person who may really have great added value in certain situations has so many limits for their pet's care. when that pet comes in with an ear infection and it asks the PT what to do. When the pet has a skin infection or has MRSA or is paralyzed or has any sort of variety of ailments, then we're putting this all. I don't even see how this is a question to put all this burden on a PT when, as we discussed, the model that exists right now in the state of California is working. People can access physical therapists. They can access some who are on our task force today. They can access the ones that work in my practice. They can access the 11 other ones that work in the city of Los Angeles. Access is there. Let's talk about protection of the consumer and best case scenario for that patient, and that includes a veterinarian on site.
Oh boy. Heller, Shala, Klingborg, Van Dijk, and Atlas, and Cariad.
That's Ms. Heller to you, buddy. I would actually, when I finish my comments, like to hear Karen's response to the question that Dr. Troy asked, because I think it's important. But I want to respond to a couple of statements that were just made. One, consumers have to decide all the time. They have to figure out all the time whether the professionals they go to for services are competent to practice. We have regulations and regulatory boards to ensure minimum standards. We have laws to implement the community's values on that. But I live in a community of veterinarians, some of which are better than others. The same is certainly true of my medical practitioners. And I have to be an educated consumer and recognize both who the good vets and the not so good vets are. And I also expect to know the difference when I walk into a physical therapist's office for my human physical therapy between what that physical therapist is providing me and what the MD is providing me. So I would not say that a consumer is going to walk into a physical therapy office and expect to receive MD treatment, and the same would be true for a veterinary consumer. Sorry, I'm losing my other point, which is really annoying because I waited a long time to say it. So I'm concerned about this notion that somehow in every community there will be the option of going to a practice where there's a veterinarian and a physical therapist on site. And I will again give you the example of my community. There is one qualified animal rehabilitation practitioner in my community. If that person no longer wants to work at the practice where a veterinarian is present or leaves town, there's nothing for me. It's a 2-hour drive for me to go to Los Angeles. So we cannot assume that urban areas are going to be the model of access statewide. Okay, now I remembered my second comment. Thank you.
Shala, Dr. Van Dijk, Karen Atlas, Cariad. Shala.
To address some of the concerns that Dr. Troy and Dr. Walden brought up, if an animal is so ill that they're going to collapse or they have an infectious disease or some kind of other dangerous illness, they have no business going to physical therapy. They should stay at the vet's office or they should be cared for at home. The other issue is Karen Atlas and Dr. Van Dijk already went over this carefully and explained that if an animal comes in, they have the training to recognize a disease process or a dysfunction that needs to be referred back to the vet. So I understand your concern and it's valid, but they're also professional medical providers and they know when to not treat an animal and when to refer it back to the vet. And I think you're also maybe underestimating the consumer as well, who's going to be bringing that animal in. Nobody knows their animals better than the consumers. I know my dog better than anybody, and I can tell when there's something wrong with her. So if I'm going to take her to physical therapy and she's acting funny, I'm going to mention it to them. Or I'm going to trust that they're professional enough to see it and say to me, you know what, I think there's something wrong with your dog. Why don't you go back to the vet? So I think there's either a misunderstanding or distrust going on about the level of care that a physical therapist can give and their medical professionalism.
Okay, Dr. Van Dijk, Dr. Klingborg, Karen Atlas.
I would echo Ms. Heller's comments and your Shala as well, that I think it's our role here is to protect the public. And in large part, that is to provide the public with access to services that are currently available and to not lock them away from the the ability to choose who they will go and see. I think we also have to protect the veterinary industry and recognize that the veterinarians should have the option to refer to someone that they think is the best qualified to treat their patient. And if we regulate them out of that option and tell them, I'm sorry, but you can't use so-and-so, who you've been using for years, by the way, because they're not under the same roof as a veterinarian, we are certainly limiting public access and limiting veterinary options.
Dr. Klingborg?
I have problems with the conversation of access. If we look at the state in terms of board certified cardiologists, there's 35 in the state. There are 35 veterinary neurologists. There are 35 veterinary dermatologists. It seems to be the secret number. There are 94 veterinary either board certified specialists in animal rehab or individuals who have the certification through the U10 program or the CRI program, 94. So there isn't this outcry coming before the Vet Med Board about a shortage of veterinary cardiologists and whatnot. It's this conversation seems to be about this one group only and access. We also keep having a conversation about being able to evaluate the quality of the services. And I have used physical therapy services as well, and I found them to be excellent. But from the PT's own website, how do we evaluate the quality of our physical therapist? 5 things. A physical therapist performed my evaluation. The physical therapist explained my treatment plan and goals. The physical therapist addressed my concerns regarding my treatment plan and goals. The physical therapist wore an identification badge. My privacy was maintained. So that's the bar that they have to cross. That's the thresholds. The point is, it's very difficult for the consumer to identify when they're getting quality services because they don't know what we know. And we have to protect the consumer in this. We keep using this word collaborate, but it's interesting because collaborate sounds a lot to me like I'm going to be over in this building doing animal rehab, but the veterinarian's over in this practice over here. That doesn't sound like collaborating to me. That sounds like being in 2 different locations. Is that better for the patient? And you did get asked a very good question, Ms. Atlas, and I'm sure that I've set you up for that, so please respond.
Thank you. So to, let's see. The first question was what is wrong with or what isn't working with the model? Is that what? It's because it's not about me. It's not about me. It's not because my model doesn't work. It's because other models can work. And we're not trying to pigeonhole everybody into, if it's already been shown 70 plus years of safety over all of the indirect supervision states without a veterinary on the premise, 0 complaints out of 70 plus years, you would think that the law of averages would catch up to us at some point where, you know, if we're that dangerous and that many things are going wrong, you're right, they're going to complain, right? The complaint process is there for a reason. So people are going to complain, right? Because that's what you guys have been saying all along is that, you know, if you are held to a standard where the consumer is going to complain and your license is at stake. So given that, if we have all of this history and factual facts, not alternative facts, facts, that there are 0 complaints over 70 plus years over all of these states that have indirect supervision for qualified physical therapists without a veterinarian on site, I think that is fair enough evidence that we are safe practitioners. And this does come down to access. I just heard Dr. Payton, I believe, say she would love to hire a physical therapist, but we're too expensive to hire. So we can't, if someone wants to work for her, and yeah, we come at a higher cost because we have an exceptional skill set and a unique skill set. But we don't have that opportunity if people aren't going to give us that opportunity. So I have many PTs that I know would love to go in this field, but they don't have the opportunity to find a vet that will either hire them and give them a fair wage, or not treat them for the professional that they are. And so it is, when we have an access issue, when we've had facts that have shown that we are not a dangerous, that we all need to be, the consumer needs to be protected from our dangerous acts that have no facts behind it, then I think it's fair to say that we should be able to be progressive enough to allow the consumers to choose their own qualified non-vet practitioner. Now, what is wrong with my model? Nothing. There's nothing wrong with this model. If in fact the fragile patients could come to my clinic, because I do have a veterinarian on site. But say I didn't have a veterinarian on site, then it is up to the referring veterinarian to decide whether that is an appropriate patient to go to a site that doesn't have a veterinarian on site. So I'm not sure exactly why this needs to be so difficult, because the facts are there. And if we can just allow access to qualified physical therapists, the consumers can decide. We had another consumer say, I don't want to go to a physical therapist. I want to go to a vet. Great, go to a vet. We're not saying you have to go to a physical therapist. We're saying we would like to open up the opportunity to have the consumer choose another non-vet professional for this area of practice. And just because we have defined it as the act of the practice of veterinary medicine does not preclude us from being able to make a regulation or legislation that allows us to overlap in scope there. So a bill can be written that would be inclusive of properly qualified therapists as long as there's a veterinarian referral. So this notion of having to be a veterinarian on a veterinary premise can only be held by a veterinarian, that really is just the same smokescreen, so to speak, for wanting to keep the PTs under the veterinarian's purview, and to keep them tied to a veterinarian premise when it's really, as facts shown over 70 years, that it's not required.
Okay.
Unnecessary.
Okay. I don't want to have to start implementing 3-minute rules, but try, in the interest of time, let's try to make it 3 minutes. Carrie Ann, Dr. Waldman, and then I'd like to hear from the public.
Hi. I would like to say that I really support what Sheila and Dr. Heller and Karen Atlas have said. As a consumer, I want more access to more physical therapy facilities, because it will be actually more cost effective for me. I would never actually take my animal to a physical therapist unless a vet referred me, because I probably wouldn't even know that such facilities exist. I would like to say, in terms of the model of healthcare that keeps being brought up, is a story of the worst case scenario. You have educated consumers, you have ignorant consumers. But the field of human medicine is coming into the 21st century, and the veterinary medicine has to do the same too. Yes, there is going to have to be collaboration between professions, and I think that when there have to be advisories made, like Senate Bill 577, which allows people to choose their health providers, providers have to include all kinds of advisories, their training, and all kinds of things. That can be done. And also, the state can also work to provide a second type of premises permit that allows for physical therapists to have indirect supervision. I'm, as a consumer, it's really important to me that things not get choked off. We do have some intelligence, and we can choose good providers. It's just really very frustrating for me to hear that kind of thing from a vet. I'm sorry.
Dr. Waldman, then members of the public.
I appreciate your perspective, and I do understand it. I really, really do. I guess when I try to take a step back out of my life experience and my job, which is my life, unfortunately, I really look at it like this. And we talked about core education for PTs today initially, and then we talked about special certifications or additional education. I don't feel like the core education that PTs have qualifies them to conduct animal physical therapy. There's no animal in there. Looking at additional education, I think it's wonderful. I think it's a great start. I don't feel like 13 days of lecture is enough for a physical therapist to conduct APR on their own without a veterinarian. And a lot of the points that were brought up recently talk about how the physical therapists want to do stuff and want to be paid more. And I just don't hear that that's about the consumer or the patient. And that is what bothers me, since my issue is all about making sure the patient gets the best care and making sure the consumer is protected so that they know that they're getting the best care. And I just want to put out there that if we were, and several people have said this every meeting, but I think I'm really good at veterinary acupuncture. I think I'm super good. Now, if I took a 13-day course on human acupuncture, would you be voting that you wanted me to do acupuncture on you because you wanted more access? Because that's really what this is about. It's not about can PTs add value. 100%. But should they be doing it on their own? Is the coursework enough? That's where I'm having the issue here.
I really want to hear from members of the public right now.
There's a couple of mics here that are hot, so if there's more than one member of the public that wants to come up, you can just take the seats where you can use mics and just take turns. Thank you.
Hello, my name is Sharon McDonough from Moreno Valley, California, and I had come up here earlier and said that I supported the unsupervised indirect supervision. That has not changed listening to all of this. I understand the worst case scenario. I'm a worst case scenario person myself. So yes, things can happen, but it reminded me of when I was having a procedure and the doctor was going through all the things that could happen. And he's a doctor, and he said, and then we could have an earthquake and you could fall off the gurney, and there's nothing I could do for you. That's going to happen. You can't plan for everything, in other words. And the other thing I wanted to say is, you speak of the limited amount you think they're getting, but in the record here, when they were talking about Western University, I mean, I'm no expert, but it says in here that the vets get 2 weeks of training for lameness. How is that different? So I don't change my position. Thank you.
Hi, my name is Dr. Peter Walsh. I'm a board-certified veterinary small animal surgeon. I'm one of the 94. I felt important that I come in front of this board just from a perspective that being a former academic at UC Davis, teaching there for 8 years, teaching not only veterinary students but surgical residents, as well as other residents in other disciplines, I think it's fairly important that we have a collaborative effort for each of those patients. I do feel a need, and I think my patients do much better with physical therapy. I've had a lot of really good success stories. What I do as far as putting the knee back together is an important part, but the big part is what happens afterwards. And it's the rehabilitation afterwards that's critical. And I know there's a lot of really good training for the human folks. I won't get in the argument about the human elbow and the dog elbow, because we could be here for 6 hours discussing that. It's completely different. But I do feel that rehab is critically important, but I also really feel that direct supervision by a veterinarian in the building is critical. Ideally, I'd like to be there for every PT exam for my patients, because my patients, the situation just doesn't change over 2 or 3 weeks. It could change over 24 to 48 hours, where my patient's doing well with a TPLO one night, then the next night not doing so well. And I'm not saying that those PT folks won't be able to identify that. I just think from a consumer's perspective, if Mrs. Smith's dog now has a seroma with the knee, the PT folks come grab me out of exam room, I look at the seroma, all of that is done within one building, and I think it's a better service for the patient, better service for certainly the client as well. Thank you.
Good afternoon, and thank you for taking the time to look at this. I'm Ken Pulowski. I'm a small animal practitioner and president of the California Veterinary Medical Association. And like Dr. Sims, I too have watched all of the playoff games. I have not seen La La Land, but I have seen Ha Ha Clinton Dix. He's a defensive player for Green Bay, so that's actually his name. So,
Harumph.
I just felt like I wanted to chime in there. So, first on the issue of, if an animal is critical and that they shouldn't be sent to an off-site physical therapist for animal rehabilitation therapy. Absolutely, and I don't think any veterinarian would do that. However, under the Colorado model, they have up to 6 months. So a patient that were I to refer out now, 4 months later, very well could have developed some critical condition that I have not seen and may not be as evident to a physical therapist who, although they've had some training, they may not recognize these critical things. So I just wanted to address that. After that, early on, as was discussed, that the physical therapists have, this wonderful training, and there is, a lot of similarities in the basic foundations, and, that's great. I understand that. And so I understand what's being asked is that with some advanced training, that they be allowed to perform their craft on animals because they have those similarities in their base foundation. Well, the same argument could be made then that because we have that shared foundation, what's to stop a veterinarian from getting some advanced training and going and performing ophthalmology on humans? Because eyes are very similar between species.
Hello again, Cynthia Wallace, California resident, Sonoma County resident. Couple of points. The discussion around direct and indirect connection seems to go back to the established definitions within the veterinary code section that was referenced earlier. And that seems to be the frame of reference here. Yet I remember earlier we were free to come up with other definitions. So next, most of the discussion has been around canines. So what do I do if my horse has a stifle injury and I need the vet and or their therapist to come to my barn? I would be perfectly fine once that therapist had conferred with the vet on taking that therapist's advice for therapy that they would provide and or I would provide and they would check on over time. So I probably couldn't get my horse in a trailer and get him someplace, like Circle Oak where I had a horse for a while. So I think looking at the definitions of direct and indirect would be useful. I think also remembering we're in the 21st century would be useful because you could have direct contact, the therapist could with the vet. You have a telephone. You can take photographs. You can get emergency response, immediate response, and have the vet engaged for the large animals. Would also work with small animals. But I come back to the consumer, and when something goes wrong, do I have to go to the physical therapy board for recourse and the veterinary board for recourse? Who's going to pull whose license? Thank you.
Hi, I'm Jamie Payton again, small animal veterinarian, moving closer. Small animal veterinarian, as I said, previous certifications. I'm Chief of Service for Integrative Medicine at UC Davis. So I just wanted to make one comment that's sort of from a different perspective, because I completely agree. You know, I have this perspective of, you know, we should all work together, but it really is upsetting to hear that the PTs have a thought that we think they're dangerous, because I actually don't think that's true at all. I think they're very valuable, and I value them. I think what we should be looking for, as when you mentioned being progressive, we should be progressive. And that's what I'm all about, is being progressive for providing the best care for the patient and the owner, as well as advancing the progression of rehabilitation itself. And so when we think about progression, it really should be done together. And, you know, I encourage the board to think about, what is the gold standard? What is the gold standard that we're trying to create for these consumers and the patients? And progression to me means working together to each use each other's skill set to really advance this area, because we learn from each other and we do the best care for our patients when we're on the same premises, when we work together. And you know, I think that's what we're missing, is we're constantly, you know, we're battling against each other, which in my view is counterproductive, because we're all here for the same goal. And the argument of access, you know, I think access is really important for consumers. But, you know, at what degree? Are we going to sacrifice what the gold standard is and the best care for kind of mediocrity because of access? I mean, finding access to, you know, good places is difficult. You know, I understand that. But I really feel that if our goal is to protect the consumer, we should really be looking to set the gold standard. Now, in addition to that, you know, the gold standard for California right now may be different than Colorado, because the last several years I've worked very hard in this area trying to educate our students, educate other veterinarians, educate consumers, our clients. And, you know, if we don't have the highest level of treatment, meaning working together and continuing to advance this area with the best means possible, not just for access, it's very hard for other people to start buying into this. And let's be honest, you know, the PTs are super valuable, but the gatekeepers for a lot of the animals are still veterinarians. Our clients are amazingly educated. I love them. And a lot of them come to, you know, this area directly, but part of the gatekeeping for education is the veterinarians. And I need to be able to tell these vets that we are striving for the best treatment for our patients. And I think that it's a mistake to think that we're trying to put other professions down, because that is not the case at all, at least from my perspective. I'm thinking, how can we all work together to continue to show the best standard right now? And in some ways, you know, it is such a new area, especially creating these rules for California. I think we should be looking for the best gold standard, the best treatment for our patients. And then maybe we modify that later on as it becomes more established, as we can continue to educate and provide the best care possible. So I just wanted to make sure that, you know, we have that perspective as well. That's all. Thank you.
Okay.
Jeff Smith, private practitioner, Middletown, California. I just want to make one last comment because it seems like there's a semantic argument going back and forth here about supervision and purview. I heard that comment made that we don't want to be under the purview of the veterinarians. We want to be able to do whatever it is we're doing. And again, I think what Dr. Payton said, you definitely need a team approach. That team needs to be led by the veterinarian. The veterinarian has a much better, bigger global picture of the animal than the physical therapist does. They have a very narrow view of what the animal is and what the potential problems are there. So I think if you accept that premise, then you have to look to the veterinarian to decide, what level of supervision are they comfortable with? Are they comfortable with indirect supervision in these situations? Are they going to put their license on the line for a facility that's 10, 20, 50 miles away? Or do they need a more direct contact with that type of facility? So I think that's a question that you have to look at is if the veterinarian is going to be the leader of this team that's in charge of the animal's health, what level of comfort, what level of control is he or she going to be satisfied with in a situation like this? Because I think the potential to do harm is very high. A dog that's nearly paralyzed with a disc bulging onto its spine, osteosarcoma develops somewhere in the limb that they're not aware of, or a puppy with a fractured femur that may be having a quadriceps contracture. Those can all have, devastating impacts, not to mention potential emergent situations like a seizure, overheating, or some unexpected bleed in the abdomen. So I think it's easy to dismiss these things as not commonly occurring, but you'd be surprised how often they happen in day-to-day practice. And if it happens once a week or once a month, that even though it's not a high frequency, it's enough that you want to be prepared to take care of it. Thank you.
We're still hearing from the public right now.
Dr. Diane Isbell, an equine ambulatory practitioner. As an ambulatory practitioner, and for most of the equine medicine, ambulatory practitioners are the backbone of the care that horses receive. Unfortunately, I don't have the time to directly supervise a physiotherapist. I would like to have the opportunity in a range setting to be able to determine, do I need to supervise this person, or do I feel that this person's skills are adequate that I don't need to supervise them? And whether I directly supervise them or not is very likely I'm going to send one of my staff along to hold the horse. Because, well, I have some clients that are PTs and great horse people. That isn't a common occurrence. And horses are big and they hurt people. So I think that it's important to have the option to care for horses. They're athletic individuals, and to determine which, whether I need to do direct supervision or am I confident in this person to do indirect supervision. And am I confident in the owner to hold the horse, or am I going to send one of my staff members along to make sure everybody stays safe? Thank you.
Hi, thank you. I'll be brief. Kelly Boyston, RVT PT. I just wanted to speak very quickly to two things. A comment was made that we don't want to be under the purview of a veterinarian so that we can do our own thing. We are not asking to work on our own thing. We are asking for collaboration with veterinarians, exactly like what we have in the human medical model. Comment was also made about all of the bad things, again, that can go wrong. I would point to Karen Atlas's data that says over 70 plus years of combined hours where therapists have been allowed to do animal rehabilitation with indirect supervision. There has been absolutely zero. I had to reiterate that, complaints that there have been any injuries to animals. Thank you.
Okay. So, I'm a Democrat, but I would have to say, over the last 8 to 12 years, I've been extremely frustrated with our elected officials in Washington because of bipartisanship. And they have dug their heels so much into their positions that I don't think anything significant has been accomplished over the last 8 to 12 years. Kind of see some similarities in this task force. And I hope that both sides recognize that some compromises have to be made. And that although it would be lovely if we could prevent all cases of harm in all situations, all of the time, we probably are not going to be able to do that. And I understand the passion and the emotion that goes behind our positions because we're dealing with animals. And whenever we talk about animals, we all go a little bit crazy. at our sunset review, all the boards had such an easy time going through their sunset review process, except the veterinary medical board, when it was a three-wing circus because everyone came to town. So we've talked about a lot of issues today. We've talked about a lot of concerns. We've gone back and forth between these concerns, and we've talked about some potential solutions and answers to these. And we've heard from the public, and we've passed one motion, and I'm hoping we can potentially pass another motion.
I'd like to make a motion.
Let's hear it.
Okay. It's like Neapolitan ice cream. There's a little bit of something for everybody here, so hang with me. California licensed physical therapists with advanced certification in APR as defined by the board. And defined by the board is referring to the advanced certification.
Veterinary medical board?
The veterinary medical board. Okay. California licensed physical therapists with advanced certification as defined by the veterinary medical board in APR may provide APR under the degree of supervision as determined by the veterinarian within a veterinary premises or a veterinary animal physical rehab premises as further defined by regulation or a range setting.
I hate to ask this because I hope you wrote it down. Are you able to repeat it?
Of course it's
Thank
written
you.
down. California licensed physical therapists with advanced certification as defined by the Veterinary Medical Board in APR may provide APR under the degree of supervision as determined by the veterinarian within a veterinary premises or a veterinary APR premises as further defined by regulation or a range setting.
Should I call for a second and we can open up? Yeah. We have a second? Okay. It's been motion and second, then we'll have this. Okay. So we'll open that up for discussion. Yes.
Can we add referring or treating veterinarian? Just to be specific and to add another level of protection for the consumer?
Under the degree of supervision is determined by the veterinarian. I think that we cannot add referring actually, Shala, because the veterinarian can only refer to another veterinarian.
Wait,
Well,
veterinarian of record?
Or what?
Veterinarian of record? Whoever's in charge of that patient, right? So it's
Veterinarian who has established a VCPR.
Veterinarian who's established a VCPR would be consistent with our Practice Act.
Yeah.
Okay.
Before going forward, that's potential amendment. We'll have to have the second degree to that potential amendment to go forward.
So I have suggested for further clarification, veterinarian with the VCPR. Shala, are you cool with that?
Okay. Dr. Sims and Dr. Van Dijk. Mike, I can't hear you.
I heard myself well. Two questions, and just to clarify in the intent and kind of operational definitions. The second premise you identify as animal vet rehab setting. That's the setting that's not in the roof of the same veterinarian. It could be the off.
That's correct.
Okay.
The veterinary APR premises does not exist except on this piece of paper. So
Right,
we
we made up right now because we're blazing new ground here, guys, and that's the hard part. It's a new
Correct.
paradigm, and welcome to the 21st century.
Okay.
And it's nice to see that we're going there. And it's any and all veterinarians, not because there are 2/3 veterinarians who didn't take the elective class that Dr. Cho talked of in their training. So this would be plenary for all veterinarians that can be that can refer to this.
We decided in the last meeting that veterinarians could practice animal physical rehab.
Right.
So
that's what
we're not parsing out one veterinarian over another.
Good, thank you. Just wanted to clarify that.
Dr. Van Dijk.
By using the term veterinary APR premise or facility, I'm concerned that we're locking in the term veterinary, which under most practice acts then imply that a veterinarian would have to own that premise. So can we?
I'm not reading it that way. When I say as further defined by regulation, it's open-ended. Who's the licensing manager?
Can we? I would request that we would amend it just to read APR facility.
So now I'm starting to feel like we're Congress again. I mean, I think if you like the intent of where we're going with this, we can sit here and wordsmith this thing all day. But if that's the hill to die on, then let's talk about that. But in the spirit of trying to move forward, say either you like the general concept of this or you don't.
I like the general concept. The one word does give me concern because in many states that would imply a veterinarian has to own the facility, and that does pretty much turn us back to where we were before we got into this.
I can see Dr. Van Dijk's point. I actually do like the idea of referring to them as animal physical rehabilitation facilities.
Before that's taken out, I need to ask Shala if she wants that word removed. Without that word? California licensed physical therapists with advanced certification as defined by the Veterinary Medical Board in APR may provide APR under the degree of supervision as determined by the veterinarian who's established the VCPR within a veterinary premises or an APR premises as further defined by regulation or a range setting.
Or range? You said it, okay.
I did.
I must stop listening. My fault, sorry.
Again, it's going to be defined later. Okay. Who was next?
I did have a question, but I'm not sure it fits here now. But my question was more about what about the potential, or does it happen that the client self-refers? Because I could imagine that if they know somebody, I'm just curious how that would work if that did happen. Like, hey, I know.
Could you repeat that question?
My question would be is if the client knows that their animal has something and maybe their veterinarian didn't say something, or that they think there's a problem, and if they're self-referring to a physical therapist, and how that would happen or work out.
That sends shivers up the spines of the PTs in Colorado when somebody comes in the door that way and they say, hate to tell you this, you got to go back and get clearance. I will not touch it. I will not risk my business on that.
Chair Nunez?
Exactly.
Yes.
In response to the question, which I think is an important one, I think that's covered by the fact that the degree of supervision is determined by the veterinarian with the VCPR. That is, there is no service without that veterinarian referral. And the veterinarian is making the determination whether it requires direct supervision or indirect, or range setting.
Okay. Val?
So just to clarify, then this APR premises that does not have veterinary before it could be a physical therapy practice without a veterinarian on site or anywhere to be seen. Is that what you're saying?
That is my interpretation of the motion. I would expect that it would meet a certain set of minimum standards for a facility, and it would have some form of licensing manager that's overseen by the Veterinary Medical Board.
And you're saying that licensing manager would not have to be a veterinarian?
Well, that's not defined. Currently, regs suggest that it does. So that may be a battle for another day, but it's not defined who the licensing manager is in this, simply that it's a premises.
Bill?
I think we would just like to see the two boards working on this rather than just the veterinary board. I mean, in terms of the training, that we also have the physical. As well as, oh, I'm sorry. We would like to have the two boards working together on this in terms of both the training requirement as well as in terms of deciding about the facility. So I think we could, if you make that an amendment.
So, want to accept that amendment? And
So there's an amendment to say something to the effect that, and we'll work, the Vet Med Board will work with the Physical Therapy Board on the regulations that we're suggesting in training. Shala has accepted the amendment, so we're still good.
Okay. Any other input from the members of the task force? Any input from members of the public? If you're going to ask who you can choke this one.
Cynthia Wallace. Clarifying question. As a consumer, I want to make sure that the veterinary individual referenced in this is licensed in the state of California to practice veterinary medicine. As a consumer, I don't want to have to deal with a multi-state board situation. Thank you.
That's a given. They wouldn't be able to practice in the state without a license.
But do we have to add somewhere that the PT needs to be licensed in California?
Yeah, we did at the beginning. It says California licensed physical therapist.
Okay.
I hate to do this. Dr. Klingberg, can you read it again with all the changes? And
California licensed physical therapist with advanced certification is defined by the Veterinary Medical Board and the Physical Therapy Board. Additional advanced certification in APR is defined by the Veterinary Medical Board, and the Physical Therapy Board may provide APR under the degree of supervision as determined by the veterinarian who has established the VCPR within a veterinary premises or APR premises as further defined by regulation or a range setting. And now having done that, do we need to add the other verbiage about the PT board? Do you think we're...
Well, we have to know.
Okay, so as defined by regulation, determined by the VMB and the PT, or a range setting.
Carrie Ann?
Well, when it comes time to second that motion, I would enthusiastically like to second that and support it as a consumer.
I'd hate to take that pleasure away from you, but somebody already seconded it.
Well,
but you can third it.
No, I want to say that I'm really happy to hear this as a motion. It sounds very inclusive and pro-consumer and pro-animal.
Another question, does there need to be verbiage about the time frame of between the VPs? I'm just curious.
I felt that the whole concept of the regulation as determined by regulations kind of starts to spell out. I mean, there's a devil in the details part of this motion, don't get me wrong. What does an APR premises look like? What does advanced training look like? By no means is the job done with this motion, but it at least provides direction, and that's what this task force was asked to do.
Waldman?
I just wanted to comment that I really don't feel like this proposal embodies what's best for our veterinary patients. I think that not having a veterinary licensee managing a case, responsible for a case, liable for a case, not to mention that the the PT's Practice Act right now says they can only practice on humans, and there's no version of that that's been amended. Seems like we're in quite a conundrum, but really it's a conundrum for the patient, and I'm pretty upset about the proposal.
Okay. Any further input from members of the board, the task force?
Dr. Nunez? I think one of the things that comes up, it's being a real learning experience being on the Vet Med Board, is the issue of veterinary responsibility. And I think what we've circled back to again and again on this is the understanding that veterinarians ultimately have responsibility for decision-making about the welfare of patients. So what I like about this motion is that it retains that authority and responsibility in the referring veterinarian with a VCPR, because that's really the core of how we understand the practice of veterinary medicine in this country, or the state, excuse me. And that we're also requiring licensing body, whatever that's going to look like,
to define pretty clearly the specifics of premises that are appropriate and of advanced training that's appropriate. Because I know one of the issues that we as consumers were struggling with was making sure that anybody doing this practice, whether a veterinarian or a physical therapist, knew what they were doing. So this puts back on the vet med board and the PT board a conversation to identify what those requirements need to be. And I think that provides the necessary level of consumer protection.
Council?
Thank you, Mr. Chairman and members. At the most risk of being the most unpopular gentleman in this room, Dr. Klingborg, your motion, is it aimed at number 10 to be the final recommendation of the task force, or do you think there's more work coming?
The final recommendation would encompass all of the other things that have been approved at previous meetings. So I don't see this one motion as the entire final recommendation. There's a nomenclature document that's been approved and motions have been passed. So I think this is one of the many things that would possibly be moving forward as part of the final recommendation.
You'll never be unpopular in my eyes.
Stand corrected. That is validation.
Hi, I'd just like to express a concern that we are trying to approach to a conclusion that we're going to help everyone happy, but we're actually not doing anything here because the terms are really broad. And as a board member, luckily I don't feel very comfortable just to vote for yeah or no until I know what that really means. So my question is actually, after we vote for this, are we going to go into a little bit detail on what the premises is, what the supervisions are, or it's done?
Well, since the motion is already on the table, you have to vote yes or no, or you can abstain. Those are your only options. As far as going into the details, I don't think it would be fruitful or appropriate to do that at this task force.
May I add that there is generally opportunity for public comment and input into the regulatory process down the line?
Plenty of opportunity.
Yeah, so you'll have lots of chances to talk to the vet med board about what you think this should look like. Lots of chances. Years of chances.
Anne-Marie, Shala, and Dr. Van Dijk.
And just one more comment for clarity, Dr. Chow, and also Lee, this speaks to this. I believe Dr. Waldman brought it up. This proposal, as we have defined what we're going to be essentially coming to a recommendation, will have to be put into effect either through legislation or regulation, depending on what the terminology is. I don't foresee any of this moving forward without some sort of legislative fix, my goodness. So you're right, in Dr. Waldman, in today's Practice Act for physical therapy, they can't do this. But this was just recommendations to determine where the changes need to be and whether or not it would be appropriate by legislation or by a regulatory proposal. And it looks like it's probably both.
I think I'm just going to echo what Anne-Marie said. I do think that this proposal was very fair in that it gives the veterinarians the option to retain complete control or to let the physical therapist work with some autonomy, but they still have to answer to the vet. So I think that it covers all of that. It gives the consumer some options as well. And I think letting some of the details be defined later is great. I think it's a springboard and it's an outline, and I think it's a great start to a compromise.
Dr. Van Dijk?
I just was kind of questioning as well, just our role as a task force, I believe, was to send a relatively broad set of directions to the board as to what we thought should happen. And then my understanding was that's the regulatory piece then takes on from there. The rules and regs part is beyond the scope of what we're supposed to do. We give them a general direction and then they fill in all the bits, correct?
That's correct.
Okay.
Any initial comments from members of the task force? Any additional comments from members of the public?
Dr. Nunez?
Yes.
Lee Heller.
Aye.
Dr. Klingborg.
Aye.
Karen Atlas.
Aye.
Sandy Gregory.
No.
Kristen Hagler.
No.
Dr. Holland.
No.
Dr. Schlachter. Dr. Sims.
Aye.
Dr. Troy.
No.
Dr. Van Dyke. Dr. Waldman.
No.
Dr. Chow.
No.
Shala Bar.
Yes.
Bill Gage.
Aye.
Carrie Ann Colley. Valerie Fenstermaker. Alyssa Silva.
Abstain.
Betsy's. So we do have an official roll call person today. 10 aye, 7 nay, okay. And 1 abstention. Okay. Okay. Motion carries.
I say it's time for a break. 10 minutes. So we are reconvened, and as Anne Marie had said earlier, this motion that just passed is going to be incorporated into the recommendations we made at the last 2 meetings. I don't necessarily think that motion about removing agenda items needs recommendations, but I dare say that our work is potentially done, because there's still a lot of details that need to be worked out with the motion we just passed, but it potentially covers licensing. This is who's going to be issuing these permits. As Bill Gage said, he would like it to be a collaborative effort between both boards. RVT licenses, PT licenses, those don't change at all. And the certification program is going to be have oversight as defined by both boards and Veterinary Medical Board. I think that potentially covers licensing, unless there's other input from members of the task force. Any input from members of the public? Again, the same arguments would be said for enforcement and discipline. This goes down to who gets choked. Those are issues that can be hashed out by both of the regulatory bodies. Consumer protection and outreach, information on the internet. Do you want to make a comments on that?
So in terms of information that's currently available, the archive of all the webcasts is on the board's website. The minutes are on the board's website. Once there are some formative decisions made about how this will progress, either through the legislation or regulatory efforts, there is always information available on public hearings, on public comment to regulations. Outreach in terms of consumer protection, that would happen once there's been a resolved document of some sort that we would be promoting to the public, as this is a change in statute or a change in regulation, and then there would be outreach efforts if it's by both the Veterinary Medical Board and the Physical Therapy Board, or by just the Veterinary Medical Board. There would be outreach efforts once there is something formative in writing that we're moving forward with.
And could you just, again, let us know what happens now?
So at this point, we will consider the final recommendations of the task force that will move forward to the Veterinary Medical Board at their April meeting. Their April meeting is, I believe, the 18th, 19th, and 20th in Oakland. I can review the decisions of the task force if that's the desire of the chair, so we know what that final recommendation looks like, or you can refer to this nomenclature document and the motions that were previously passed, in addition to the motion that was made earlier this afternoon.
I don't particularly see a need for you to review that unless someone else does.
So at that point, the Veterinary Medical Board would also take a position on the recommendations of the Animal Physical Rehabilitation Task Force, and both those recommendations would be communicated to the legislature.
And it's an open meeting? Open
Yes,
to the public?
the board meetings are all open to the public. And they're also webcast.
Chair Nunez, may I say something? I wanted to again thank everybody who's participated in this process. People who've taken time off of work, who've flown long distances, including Dr. Van Dijk, who came from Australia in order to be here today. And I really express my appreciation to the members of the public who've taken time out to come and speak to us. I understand some of the frustration that the veterinarians feel if they think somebody else is engaged in their field of practice when I watch you guys try to be lawyers. It's pretty funny. But I appreciate that everybody really wants to engage in a serious and thoughtful discussion of the issue, and so I'm really appreciative of the efforts you've all brought to this.
Do we still have diplomatic relationships with Australia? All right. Okay. Karen?
In terms of consumer protect, more of the outreach part, would there be a possibility for the CPTA and the CVMA to actually work together to come up with a joint effort to educate the consumers about what we've been able to do and how and for what the consumers can look for in terms of finding qualified practitioners? Could there be like a joint, like a collaboration between the two associations to help with an outreach effort for education? I don't know if that's something we talk about here or
I think
what.
there should be, but I don't think this task force can make a recommendation to either of those organizations. Kurt, would you like to talk about agenda item 9F?
Not really, Mr. Chairman.
And that's fine with me.
If the body wants me to talk wax philosophic about it, I can. But I believe that honestly, this task force has made some good progress. I'm not sure that the provisions and the findings in North Carolina would in fact hold, since we are in this capacity. So North Carolina really stems from enforcement and the regulation. This body is not charged with any of those things.